Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm going to be covering bulimia nervosa. And while I'm talking about that and teaching about that, I'm going to keep reminding you of the differences between bulimia and anorexia, because for testing purposes, you are expected to know the difference. Before I get started, guys, please like this video. Press that red notification button, subscribe to this channel if you haven't done so already. And don't forget, I have audio lessons available for you on my website at nexusnursinginstitute.com. Now, before I get started, I have to give you a heads up. I am Mama Bear. I'm not home too often on the weekends, but when I am, I have all of my nieces and nephews at my house. This is where they like to congregate, swim in the pool, play football, soccer, or whatever. So during this video, if you happen to hear screaming or one of them bust through the door forgetting I told them that I'm recording, don't worry about it. Let's keep going. All right, so let's start, guys. Bulimia nervosa. Look at what this says. It says individuals with bulimia nervosa engage in repeated episodes of binge eating followed by inappropriate compensatory behavior such as self-induced vomiting, misuse of laxatives, diuretics, or other medications, fasting, or excessive exercise. All right. So in bulimia, they will eat. That's when they're binging, right? And then they feel guilty. They're like, oh my gosh, what did I do? So they'll take a whole bunch of diuretics, or they might stick their finger down their throat to make them vomit, or they may like exercise excessively because they're trying to burn the calories, right? Or they may take medications to try to get it out one way or another, or even suppress their appetite. So, and a big difference, guys, between this bulimia and anorexia is because in anorexia, they try to stay away from food. They're not binge eating then purging. If anything, they just be trying to purge, but they're not trying to eat, right? But in bulimia, they'll binge eat first, have a sense of guilt, and then try to purge. That's one of the big differences. So make sure you know that. Look at what else it says. It says this disorder is characterized by a significant, that means a whole lot, a significant disturbance in the perception of body shape and weight. Same thing as anorexia. Let's look at the DSM-5 criteria for the patient being diagnosed with bulimia. What does it say? Recurrent episodes of binge eating. So it's not just a one-time affair. It keeps happening over and over and over again. An episode of binge eating is characterized by both of the following. So it has to have both 1 and 2. Look, 1, eating in a discrete period of time within any 2-hour period, an amount of food that is definitely larger than what most individuals will eat in a similar period of time under similar circumstances. So for example, for lunch, you may decide to go to Burger King and have a number 2. This person for lunch will go to Burger King, have a number 1, 2, 3, 4, 5, 6, 7, and eat it all in one sitting. You see the difference? Here's number 2. A sense of lack of control over eating during the period episode. During the time that they're binge eating, they cannot stop themselves, okay? Feeling that one cannot stop eating or control what or how much one is eating. They have to have both of these. Let's look at B. I want to show this to you. Recurrent, inappropriate compensatory behavior to prevent weight gain. Let me stop right there before I keep going. You know, here we go. What do they mean when they say compensatory? When you see that word compensatory or compensate, that means to make up. So the patient ate, and now they're trying to make up for that bad behavior. That's what they mean when they say compensatory, okay? Recurrent, so this keeps happening. Recurrent, inappropriate compensatory behavior to prevent weight gain, such as, let me tell you something. When you guys are studying and you see them giving you example, comma, example, comma, example, comma, guess what? That's a select all that applies. That is what is most likely to be a select all that applies on your nursing exam. So you need to know these examples: self-induced vomiting, misuse of laxatives, diuretics, other medications, fasting, or excessive exercise. So let's look at assessment. What would this patient look like? By the way, the video I did on anorexia nervosa, someone was asking what book I was teaching out of. This is a great book. If you're weak in mental health and psych, I encourage you to get it. So I already answered that, but for this video, I'll let you know. How do I pronounce this? Varkarelis, what do you see it? This one right here. That's the name of the author. Foundations of Psychiatric Mental Health Nursing, 8th edition. I'm sure there's has to be a 9th edition by now, but the author of this book, I think, is great. That's why I like to teach out of it, because they give you the information in simplistic terms. So anyway, assessment. What are the clinical manifestations that we expect to see in a patient that has been diagnosed with bulimia? Initially, patients with bulimia nervosa do not appear to be physically or emotionally ill. It's not like that patient that has anorexia that as soon as you see them, you're like, whoa, what's wrong with them? Because remember, in anorexia, they tend to be what? Very skinny, emaciated. They look like they're wasting away. But the people with bulimia, they tend to be usually around their ideal body weight, a little bit heavier or a little bit less, but around there, you know, you won't be shocked when you see them like you'll see the patient with anorexia. They are often at or close to ideal body weight. Why do I keep going between bulimia and anorexia? Because you're going to be tested on that. You have to know the difference. The patient may have enlargement of parotid glands, dental erosion, and caries if the patient has been inducing vomiting. And I know I put HESI here, but this same concept you will also see on your nursing ATI exam. You may also see on NCLEX. They expect you to understand that. You have to use your critical thinking. Who is more likely to have abrasions on their knuckles? The patient with anorexia or the patient with bulimia? The patient with bulimia, because it's a patient with bulimia that is most likely to self-induce vomiting. So what happens as they're leaning over the toilet to throw up, they're leaning on what? Their knuckles. Okay. The reason that we see that all their teeth is rotted out is because they're vomiting so much. Remember, when they're vomiting, they're trying to get the food out of their stomach. But what else is in the stomach? What breaks down that food? Hydrochloric acid. So as that hydrochloric acid is coming back up, it's burning the inner lining of their stomach. It's burning the oral mucous membranes. It's taking away the, I'm forgetting the name, but the covering of the tooth, the enamel, right? It's cutting through that enamel. That's your bulimia patient. Make sure you know this. Self-assessment. In building a therapeutic alliance, you're trying to help that patient, you want to work towards their goals as a team, try to empathize with the patient's feelings of low self-esteem, unworthiness, and dysphoria. They just told us more clinical manifestations that we know that this patient's going to have. They are going to have feelings of unworthiness, hostility, anger towards who? Themselves. Okay? Dysphoria, they may look in the mirror and they see themselves big as a house. If you believe the patient is not being honest, active binge eating or purging goes unreported, or is being manipulative, acknowledge such obstacles and the frustrations they provoke and construct alternative ways to view patients' thinking and behavior. Call them out on their BS. You want to do it in a therapeutic way, but call them out, because that's the only way that we can get them to their goals. So if the patient, you feel like they're lying to you, they just ate and then they snuck to the bathroom, they came back like nothing happened, call them out on it. Say, you know, Miss Such and Such, you just had lunch and you didn't wait for your caretaker to go to the bathroom with you. I saw that you kind of snuck off, went by yourself, and now you're back. Did you self-induce vomiting? It must be very hard for you to stop this, because I know that sometimes you feel like you can't help yourself. Acknowledge it, but call them out on it. This is what they're saying. Assessment guidelines. Determine the patient's perception of the problem or chief complaint. Before you can ever help a patient, before you can ever teach them, what's the first thing you're supposed to do? Find out what they already know. Find out what they're thinking in their mind, because when they start talking to you and tell you what they're thinking, that's how you know what it is that you need to correct. That's how you know where your teaching is going to start. Perform a complete nursing assessment, including vital signs, review of systems, general appearance. You want to do a psychosocial history. Assess nutrition pattern and fluid intake. Because yeah, they're binging a lot, but they're also what? Purging a lot. So we want to make sure that patient's not having any electrolyte imbalances. They're not having any nutritional deficiencies, vitamin deficiencies. Assess binging and purging patterns with, look at this word, where's my pen again? With direct questions. Don't beat around the bush with this type of patient. You have to be direct in a kind manner, but you have to be direct, okay? Assess daily activities, including exercise. How often are they exercising? Are they exercising in a healthy manner? Or are they exercising, excuse me, I'm taping, I'm filming. I am filming. What do you need, baby? Matthew? As I was saying, are they exercising to be healthy? Which in this case, probably not. Or are they exercising because of that guilt they felt and they don't want to gain any weight? And so they're trying to, that's their way of trying to purge. So you're going to assess that. Review laboratory testing. You want to look at the fluid electrolytes, glucose, thyroid function test, CBC, especially that H&H, RBCs, ECG, same as what? Anorexia. And of course, elicit the patient's goals for treatment, because you guys are working as a team to reach those goals. Look at this box up here. Thoughts and behaviors associated with bulimia. Binge eating behaviors where they're eating and eating and eating and eating excessively. Often self-induced vomiting by either laxatives or diuretics after binging, because remember I told you they just feel really guilty and then they try to get rid of that food. Depressive signs and symptoms, problems with interpersonal relationships. They can't keep a romantic relationship or even close social relationships. Self-concept, impulsive behaviors, where if something happens that causes stress, instead of dealing with the cause of that stress, they do what? Run to food and then feel guilty and try to get rid of it. Increased levels of anxiety and compulsivity. They don't know yet how to deal with stress. Their way of dealing with stress is by eating. So part of the goal is to teach them how to recognize, one, how to recognize when their anxiety starts to rise, and two, how to deal with it in a healthy manner instead of going to food. Possible substance use disorders. We often see that as a comorbidity with both anorexia and bulimia. Possible impulsive stealing. Sometimes we see this in the bulimic patient as well. Possible signs and symptoms of bulimia and the cause. I'm not going to go over all of them, okay? But look, again, normal to slightly low weight. The cause, excessive calorie intake with purging and excessive exercising. So even though they're eating, they're doing excessive purging as well. That's why we usually tend to see them around the ideal body weight, give or take a few. Dental caries, tooth erosion. I already explained why, because all that hydrochloric acid that was in their stomach burns their throat coming up, burns their mouth, eats through that enamel of their teeth. Parotid swelling because of that hydrochloric acid, okay? And the rest you can read. Oh, this is important too, hold on. The abnormal values, the electrolyte imbalance, hypokalemia. Last time I checked, Potassium being outside of that therapeutic range of 3.5 to 5 can kill a patient. So that's definitely a priority. Hyponatremia, cardiovascular abnormalities. They can even go into cardiac failure. Signs and symptoms, nursing diagnoses, outcomes for bulimia. You guys can read all of this on your own, but I will touch on what are going to be priorities for you. Absolutely, the electrolyte imbalance, because that can kill a patient very quickly, right? Cardiac problems. Your decreased cardiac output, that's going to be a priority nursing diagnosis. Risk for injury. Why? Because of the electrolyte imbalance. And yes, of course, guys, disturbed body image, that is a problem. But when we're prioritizing, what's going to take priority? Their disturbed body image or that cardiac output? The cardiac output. What's going to take priority? That disturbed body image or risk for injury? Risk for injury. So yes, disturbed body image is a problem, but whenever you get a test question that's asking you about a priority, always think to yourself, what's going to kill my patient the fastest or keep them alive the longest? And that's always going to be your priority. And you guys can go over the rest of this. Let's talk about planning. Like the patient with anorexia nervosa, the nurse must prioritize care that addresses life-threatening complications. Our priority is always going to be what kills the patient the fastest or keeps them alive the longest. Criteria for inpatient hospitalization include syncope, where they're passing out, serum potassium of less than 3.2. Potassium has a very narrow therapeutic range. That's how we kill inmates in Florida. Okay, potassium range is 3.5 to 5. Anything out of that range can give the patient cardiac dysrhythmias and kill the patient. Serum chloride of less than 88 MEQs per liter. Esophageal tears because of that hydrochloric acid. Arrhythmias, intractable vomiting that can cause severe fluid electrolyte disturbance. And hematemesis, I can't pronounce this word. Hematemesis, you see it. It means blood in the vomit, okay? And we see this because what happens is that hydrochloric acid just keeps eating away at the lining, eating away at the lining, eating away at the lining. Then it starts to cause ulcers, and the patient, when they vomit, will see that vomit blood tinged, okay? Hematemesis, suicide risk in this population also requires hospitalization. You guys know that. When you even suspect that a patient's suicidal, you don't beat around the bush. You ask them directly, are you having thoughts of harming yourself? And if they say yes, you ask them, do you have a plan? And if they say yes, you ask them, what is your plan? And the reason you're asking them what their plan is, you're trying to figure out the lethality of their plan. So if we're in South Florida and they say that they plan on killing themselves by throwing themselves off of Mount Everest, okay, it can happen, but that plan, we're not as concerned about them committing suicide right now than if they said, well, I plan on shooting myself. And then when you ask them, well, do you have access to a gun? And they're like, yeah, at my grandfather's house under the bed. Okay, so you always ask directly, do you have plans of hurting yourself or killing yourself? If they say yes, do you have a plan? They say yes, what is your plan? And do you have access to whatever that means of killing yourself that you have? Very important for you guys to know. Moving on. Pharmacological interventions. Fluoxetine, Prozac, that's an SSRI antidepressant. It's been approved by the FDA for acute and maintenance treatment of bulimia nervosa in adults. You need to know this. This has been seen on NCLEX so many times. By the way, SSRI, this class of antidepressant, that is our #1 go-to antidepressant. Patient has depression, you expect the doctor, the first line treatment is going to be an SSRI. But something you need to know about the SSRIs, they are wonderful for depression, but they're also a great drug for bulimia, okay? When fluoxetine is used for bulimia, it is typically at a higher dose than if you were giving it to the patient just for depression. Health teaching and promotion, you're going to teach relaxation techniques, because remember, what started all of this is that patient's anxiety about whatever it is that happened, right? Teach them relaxation techniques, maintenance of a healthy diet and exercise, coping skills. So once you start to get anxious, once you start to get stressed, instead of going to food, you have healthy coping mechanisms. The physical and emotional effects of binging and purging, and the impact of cognitive distortions. Cognitive, how you think. Teamwork and safety. Observation during and after meals to prevent purging. Same thing with anorexia. Normalization of eating patterns. Same thing with anorexia. And maintenance of appropriate exercise are elements of such a unit. Because remember, this type of patient wants to exercise excessively. We want to teach them healthy exercise patterns. Same with anorexia. All right, so down here is a case study about a patient with bulimia. I'm not reading all of this. Let's get to the point. Over here, short-term goals and interventions. Short-term goal. Patient will identify the signs and symptoms of low potassium level, and potassium level will remain within normal limits. What's the normal limits? 3.5 to 5. So why are they talking about potassium? Because we know this patient is what? Purging a lot. And with the hydrochloric acid, with that food comes what? Potassium. And we know that potassium is so deadly if it's outside of the narrow therapeutic range of what? 3.5 to 5. So that's a very important priority. So what are we going to do? Educate the patient regarding the ill effects of self-induced vomiting on the potassium level. Just like base comes out the butt, the other way, when you're vomiting, patients losing potassium, they can become hypokalemic. Educate the patient about binge purge cycle and its self-perpetuating nature, that, they can't think to themselves, oh, I'm just going to do this one time. No, they're going to keep doing it over and over and over again. It's a horrible cycle. Teach the patient that fasting sets one up for binge eating. Because when you fast, you're going to get to the point where you're starving and you eat more than you should. So you need to eat 3 healthy meals and healthy snacks in between those meals. Do not fast, because you're just setting yourself up for failure. You're going to end up binge eating. Explore thoughts that trigger binge eating. Do you start thinking of yourself as fat, then you start binge eating? Or do you start thinking about the childhood trauma that you had, then you start binge eating? What is it? What is that thought that you have right before you start binging? Because whatever that thought is that you had right before you start binge eating, that's what's causing the anxiety to make you turn to that food. Challenge irrational thoughts and beliefs about forbidden foods. You have to teach that patient that they can eat anything in what? Moderation. That's your key. Teach the patient to plan and eat, look at this, that's your key, regularly scheduled balanced meal. Oh, and that's it for bulimia. That was quick, guys. So let me know what you thought about this video in the comments. Let me know if there's anything in psych that you're struggling with that you'd like me to do a lesson on. Don't forget, guys, I have audio lessons available for you on my website, nexusnursinginstitute.com. If you have a test coming up and you need a very high grade on that test so you don't flunk out, you're at your wit's end, you need to check out my audio lessons on my website to help you out. Thank you so much for watching this video, guys, and you'll see me on the next video.